I'm really delighted to be joined tonight with several of my cherished colleagues, all really wonderful people and experts in their field. And so we're going to be starting out talking about some surgical options, followed by some clinical trials, and then we'll talk about systemic therapies. And then we'll end tonight with insights on radiation therapy. And as you mentioned, this is the second part of a three-part series for which we're really focusing on the treatment part of what's happening in breast cancer for Breast Cancer Awareness Month. And so it is really delightful to be here tonight. Our first speaker is Dr. Matthew Sporn. He is our breast surgical oncology fellow here, and he had completed his medical degree at St. George's University in the Caribbean. And he became he began his general surgery residency at SUNY Upstate Medical University, during which he undertook dedicated research training at the NIH, the National Institute of Health. And there he completed a research fellowship in cancer immunotherapy and surgical oncology under the mentorship of Dr. Steven Rosenberg. And then following his research fellowship, Dr. Sporn finished his general surgery training here at NYU Langone Health, and where he is now our breast surgical oncology fellow. So, Matthew, take it away.
Great. Thank you so much for that introduction. So as mentioned, my name is Dr. Matt Sporn. I'm the Breast Surgical Oncology Fellow here at NYU. I'll be presenting on the surgical techniques beyond the standard lumpectomy. So a little bit about what we'll be talking in this talk tonight. So I'll go through a quick introduction. We'll talk a little bit about what oncoplastic surgery is. How do we choose some of these oncoplastic techniques? What are the postoperative implications of using these techniques? And then also some of the mastectomy variants that we are now using, as well as patient selection, counseling, and then we'll have a few minutes to open the floor up for questions. So the surgical management of breast cancer has evolved from radical resections to now breast conserving therapy and aesthetic focused approaches, all while maintaining oncologic safety. Standard lumpectomy and mastectomy remain the cornerstones of surgical excision. However, some newer methods have expanded the eligibility for these breast conserving therapy surgeries. Additionally, advances in mastectomy techniques have further enhanced reconstructive options for patient satisfaction. And so when we talk about the evolution of breast surgery, we really have to talk about the historical aspect of this. And back in the 1890s, Dr. William Halsted first coined the radical mastectomy. However, this was a really extensive resection with a high morbidity. And we can see a quick picture of it over here on the right-hand side, whereby all of the skin, breast tissue, lymph nodes, and even the pectoralis major and minor muscle were all removed. And then in the 1970s and into the 1990s, we really shifted to more of a modified radical mastectomy, whereby a very similar surgery, however, leaving the muscle, and now the total mastectomy, whereby we really just take the nipple areolar complex and a skin paddle, as well as all the breast tissue, leaving the lymph nodes and the muscles all intact. Following that, in the 1990s and into the 2000s, breast conserving therapy was validated as oncologically safe. And we can see an example of that here on the right-hand side, where we have a breast lump that was in this patient. We make a small incision. We're able to remove the tumor in the surrounding tissue itself, suture it back up, and that is shown to have good cosmetic as well as good oncologic outcomes. And since then, really the rise of oncoplastic as well as nipple and skin sparing techniques have been integrating form and function into these types of surgeries. So what is oncoplastic surgery? Well, it combines tumor excision with plastic surgery techniques to optimize cosmesis. And ultimately, this expands the feasibility of lumpectomies or partial mastectomies by addressing these defects through tissue rearrangement or transfer. And there are really two main categories of this type of surgery. Level one, which is going to be really smaller volume resections that are going to be able to be achieved with local advancement and small little types of procedures, as opposed to level two, which are going to be larger volume resections and are going to require more extensive plastic surgery techniques to improve the cosmesis. And again, as I'll keep saying, really the goal is to achieve clear margins and have a good oncologic surgery, all while maintaining the contour and symmetry for patients' own satisfaction. So the two real ways of that we're able to do these oncoplastic surgeries is with volume displacement, where we're able to use the local tissue in these after partial mastectomy to be able to close. And then this is in contrary to volume replacement, where the local tissue is inadequate, and we're able to use autologous or patient's own tissue flaps to restore the volume. So what does this look like? I think probably the easiest one to understand is this local tissue rearrangement. And we actually do this with most lumpectomies additionally. On the left-hand side here, we can see a tumor and the surrounding tissue is resected, and we can see a large defect here where that was taken out. And so what we're able to do is we're able to mobilize some of this tissue on both sides, stitch it back up together, close the skin, and we're able to have a good cosmetic outcome with no dimpling from where this tumor was removed. Some further examples here on the left side of volume displacement are going to be a batwing mastopexy, which combines our lumpectomy with a breast lift. And so we can actually see here on the left-hand side, we can see a really nice cosmetic outcome of the left-sided breast after this tumor and mastopexy was performed. Another example is here on the left-hand side, we can see an inferior reduction whereby the tumor and the surrounding tissue is removed, and then a pedicle of skin is mobilized and able to swung down into this cavity to fill the defect, and then the skin is all closed around it, again, combining both the tissue rearrangement with a reduction. And so this is in contrary to the volume replacement that we can see here on the right-hand side, whereby we take a vascularized pedicle of skin, soft tissue, and sometimes muscle from the axilla or from the armpit, are able to swing it into the breast to fill in any defects that may be there. And this is especially good for some of those lateral defects. As you can imagine that because it is surviving on just this one artery, it cannot be moved all the way to the middle or sometimes the lower portions of the breast, but is really good for these lateral defects. Another example, we can see a tumor that is taken out here, and then this muscle and the skin and pedicle is swung into the breast to fill in that gap there. And we can see a few examples of this here on the right-hand side, on the top and on the bottom, preoperative in A and the postoperative in B. And we can see really nice symmetry on both sides, and again, a very nice cosmetic outcome for these two patients here. And so there are quite a few oncoplastic surgery techniques that we have in our armamentarium. And so not to go through them all right now, but just to say that no matter where in the breast a lesion may be, we potentially have a oncoplastic technique that can be used in order to do a lumpectomy. So how do we choose some of these techniques? Well, ultimately, the most important thing is going to be the tumor location and size. If the tumor is too large for the breast, or even for some of these different oncoplastic techniques, it is still possible that a patient may benefit more from a mastectomy. However, depending on where the location is, these different types of flaps or different types of rearrangements are going to be possible. We also have to consider the breast volume of what is there versus what they would like to have afterwards, the ptosis or the sagging or droopiness that someone may have, as well as the symmetry. A lot of our patients will actually undergo a symmetrizing or a symmetry procedure on the other side so that both sides will look the same. Some other considerations that we'll get into are anticipated radiation therapy, as well as the patient's own preferences and comorbidities. An example of comorbidities is someone who is a smoker may not be the best candidate for some of these different local or regional flaps. And so again, as I'll keep harping, the goal is to achieve oncologic safety with these optimal cosmetic outcomes. So radiation and re-excision considerations. So these oncoplastic reductions or rearrangements can affect the postoperative radiation planning. Partial breast irradiation or irradiation to adjust the lumpectomy specimen and lumpectomy site not be feasible due to this altered breast anatomy, and the patient may have to undergo whole breast radiation. Additionally, re-excision may be difficult unless the tumor bed is marked with clips, and even then it may not be possible due to this altered breast anatomy. Additionally, early operation may aid in localization if necessary, as the tissues have not healed yet, and it may be easier to find where you're looking to go. Additionally, close coordination with plastic surgery and radiation is going to be imperative. Moving on to some of the different mastectomy variants that we now have and use quite often is going to be the skin-sparing mastectomy. We can see that here on the right-hand side. This is going to remove the breast glandular tissue as well as the nipple areolar complex while preserving the majority of the skin envelope. This enables immediate reconstruction with improved aesthetic results, and this is indicated for early-stage tumors without skin involvement. A similar variation is going to be the nipple-sparing mastectomy that we can see here on the left-hand side and here on the bottom. This is going to preserve the entire skin envelope with the nipple areolar complex while removing the entire underlying breast tissue. Again, this is going to offer superior cosmetic outcomes and physiologic satisfaction. And this is going to be indicated for early stage tumors that are away, again, from this nipple areolar complex. And during surgeries, to make sure that we are being safe with keeping the nipple areolar complex, we always biopsy that region there to make sure there's no cancer that's being left behind. And so how safe are these? Well, actually, our group here at NYU has extensively looked at the safety of these techniques, and we actually have a 10-year follow-up with one of the largest case series in the world, and they all really demonstrate good cosmetic outcomes with good oncologic safety. Patient selection and counseling. So some factors influencing surgical choice are going to be the tumor biology. Someone with a more aggressive tumor may not be a good candidate for some surgeries, but maybe a better candidate for others. As I had said, the breast size, any sagginess or drooping that may there be, as well as the tumor to breast ratio. Additionally, patient comorbidities, lifestyle, and personal goals always come into play. Counseling is going to include discussion of cosmetic expectations, possible complications, and adjuvant therapy impacts. And the most important thing, again, is to align the surgical approach with both the oncologic and psychosocial well-being of our patients. And so in summary, breast cancer surgery has evolved to prioritize both oncologic safety and aesthetic outcomes. Standard lumpectomy remains foundational. However, oncoplastic and reconstructive techniques have extended breast-conserving therapy eligibility. Oncoplastic techniques allow larger resections while maintaining shape and symmetry with volume displacement with local tissue rearrangement or volume replacement with local or regional flaps. And then skin sparing and nipple sparing mastectomy techniques preserve the native skin and improve cosmetic and reconstructive potential. Postoperative therapies must be considered. Again, oncoplastic rearrangements may preclude partial breast irradiation and complicate re-excisions. And then most importantly, multidisciplinary planning involving surgery, plastic surgery, medical oncology, and radiation oncology ensures optimal oncologic and cosmetic outcomes. Quick plug for our breast surgery here in Brooklyn at Bellevue in Manhattan. A huge thanks for Dr. Axelrod for helping me prepare this talk, as well as Long Island, Nassau. Thank you, and we'll open the floor to any questions.
That's great. Thank you, Matthew. That was really awesome. We do have a couple questions that have come in that I hope we'll have time to. One of them is, should I do reconstruction at the same time as my mastectomy or later?
Question that we actually comes in almost every day. And honestly, it kind of depends on what pathology is and what types of adjuvant therapies you need, as well as what functional outcomes you're looking for. A lot of the times that we'll have our plastic surgeons place tissue expanders. If you're going to need radiation afterwards, the patient will get radiation and then get implants later on. Or sometimes we'll even do delayed reconstruction where the patient will get tissue expanders, get radiation, and then an autologous flap, like a deep flap or something like that. So it's a little hard to say, but we try to do it immediately if we can, but sometimes we do have to delay it if need be.
Our next topic is going to be systemic therapies, and our featured speaker tonight is Dr. Ira Z. She is an associate professor at the NYU Grossman Long Island School of Medicine. She's also the medical director of clinical operations in medical oncology at NYU Langone's Perlmutter Cancer Center in Long Island. She's a breast medical oncologist and an integrative medicine researcher, and she's dedicated to enhancing patient experience, streamlining infusion operations, and developing collaborative programs that really bridge clinical excellence with holistic patient centered care. And I can definitely attest to that. So here you go, Iris.
So good evening, everyone. Thank you so much for joining this webinar to talking about the breast cancer treatment options. I'm a breast medical oncologist by training, and today we will spending some time to talk about the systemic therapy for breast cancer. First of all, most of my patients are not happy to come in to see a medical oncologist. They're very concerned about the side effects of the systemic therapy. Hopefully, in the next 15 minutes, we can walk through what is the systemic therapy means for us, what's the options, and something new on horizon, and help to understand and making decision during the care. So I don't have any financial conflict of interest, and this is really for communication, community education purpose only. I will only discuss the standard of care and FDA approved indications. So the first question is that what is systemic therapy? If you're thinking about a systemic therapy, it's different from surgery or radiation. It's really delivering those cancer-directed therapies through the bloodstream to reach the cancer cells throughout the body. Often, when we present with breast cancer diagnosis, we first wanted to do is to staging the cancer properly. Roughly we define into early stage, which means the tumor is localized, or metastatic setting, which means that tumor has to travel beyond breast and the surrounding lymph nodes. Systemic therapy can treating the breast cancer, either localized disease or metastatic disease. And then when you're thinking about the systemic therapy, it's actually beyond the conventional thinking of the chemotherapy with the IV drip. Currently, we have many options of oral drugs and intravenously given drugs, but ultimately, those drugs are really delivered to the cancer cells via bloodstream. The whole purpose of this systemic therapy is really prevent disease coming back or treating the cancer to make sure that they not spread beyond the breast. And then when you're thinking of the category of under the systemic therapy, now in addition to the conventional chemotherapy, we have a multiple novel agents of endocrine therapy, target therapy, ADCs, which I'm going to talk later on, and immunotherapy. So this is a really exciting time for us to thinking systemic therapy. And in the past decade also, in this area, we have made so much improvement and for our breast cancer patients and their outcomes. It's hard to talk about systemic therapy without talking about the subtypes of the breast cancers. So every single breast cancer diagnosis, your doctor will checking 3 markers on the on the cancer cells. They are defined by estrogen receptor, ER, progesterone receptor, PR, and HER2 stand for human epidermal growth factor receptor 2. Those 3 markers are extremely important because this determines the major subtypes of the breast cancer. If you have ER/PR positive, HER2 negative disease, this is the most common subtype of the breast cancer. For patients who has a HER2 overexpression, is considered a HER2 positive breast cancer. If the tumor does not have any expression of ER/PR or HER2, this is falling into the bucket called triple negative. The doctors are really using those receptor status to determine what's the best treatment. And then if you're thinking out loud, actually the breast cancer is considered one of the first cancer being subtyped based on molecular biomarkers and providing target therapy, which means that really deliver the systemic therapy based on the ER/PR and the HER2 expression. So first, I want to talk about the endocrine therapy. A lot of people also call it as a hormonal therapy. I wanted to clarify in this situation that endocrine therapy used in breast cancer subtype, which is positive for estrogen receptor and the progesterone receptor. In this type of breast cancer, the cancer cells extremely sensitive to the estrogen pathway. And then when we're referring to endocrine therapy or hormonal therapy, we wanted to thinking about actually this group of drugs works by blocking the hormone that stimulate or help cancer grow. A lot of time patients come to the clinic saying, oh, can I take a hormone therapy? This is different from the hormonal replacement therapy. It's actually functioning opposite. There are multiple drugs in this category, for example, tamoxifen and aromatase inhibitors. Lately, we also have some oral options called oral SERDs. And then in this category, we actually downgrade estrogen receptor directly from the cancer cells. CDK4/6 inhibitors are newer drug class. It actually has been found that in combination with endocrine therapy, it significantly improved patient survival and decreased recurrence. And then when you're thinking of this group of drug you're thinking about endocrine therapy is actually stopping the estrogen receptor pathway signaling message and then inhibit the tumor cells growth. Chemotherapy is something a lot of people are so afraid of. When people talking about the chemotherapy, they thinking patient got really sick and has a lot of nausea, vomiting. I think, with a lot of anti-emetic meds development, chemotherapy is very well tolerated. The idea of the chemotherapy is that chemotherapy, killing rapidly dividing cancer cells, particularly those aggressive tumors such triple-negative breast cancers. Chemotherapy come in most in IV form, but also oral pills. And then we could give chemotherapy either before or after surgery in a locally advanced breast cancer. So those chemo drugs, they actually cannot differentiate tumor cells versus healthy cells. So a lot of time they also can killing of healthy cells, for example, the blood cells, and causing side effects such as low white blood cell counts and anemia. The purpose of the chemotherapy has multiple layers. One is that if patients have a locally advanced breast cancer, often we consider giving chemotherapy to shrink the tumors before the surgery, or we're utilizing the chemotherapy after the surgery to reduce the recurrence risk. In the metastatic setting, when we run out the options of endocrine therapy or target therapy, chemotherapy remains the mainstay of the therapy in those situations. I wanted to introduce a novel class of drug called antibody drug conjugates, abbreviating as ADCs. ADC is a really smart drug. In this graph, it illustrates that in the magenta color is the antibody, and then there's a tiny chemo molecule attached to the antibody. This group of drug, you actually bring the chemo molecule into the cancer cells and then create a very high localized concentration, causing the killing effects. And currently, we have a couple drugs already approved in this space, and some of them you might already heard of. In the HER2 positive space, we have TDM1 and ENHERTU. And then in the HER2 low space, we have ENHERTU approved. And then we also have a TROP2 target, sacituzumab. And I have to say there's another drug I didn't put on this, is the Dato, also got approved in metastatic hormonal positive breast cancer. Fundamentally, I treat patients with ADCs. I tell them this is still belongs to a chemotherapy drug, because ultimately the way it kills cancer cells is by utilizing the antibody as anchor and then bring this chemo molecule into the cancer cells. This has the benefit create a very high local concentration compared with the conventional chemotherapy, and then to avoid a certain toxicity in general otherwise we couldn't tolerate. The last one but not least is the target therapy. The target therapy has been expanded very rapidly in the breast cancer. We actually identified a couple specific genes, mutations associated with tumor growth. And then based on those scientific findings, we developed a specific drug against those type of mutation. For example, PIK3 mutation is a very common mutation we found associated with breast cancer. Currently, we have multiple drugs targeting PIK3 mutations. Similar, we also have AKT inhibitors. Previously, I introduced the concept of the oral SERDs, which is a class of drug that degrading the ER pathway, the estrogen receptor. And then we also found after patients seeing endocrine therapy, often they develop this ESR1 mutation, which is induced constant activation of the ER pathway. And then this is actually considered target therapy, particularly for those ER mutated patients populations. PARP inhibitor is a class of drug targeting on the BRCA1, the BRCA2 mutation carriers. We do have olaparib and then talazoparib approved in this situation. And then the last one is the HER2 targeted tyrosine kinase inhibitors. And we have multiple drugs in this space based on the HER2 expression. So how we select which target therapy is suitable for us? Very important that we have so many modern technologies and to genomic testing, for example, the Oncotype MammoPrint to help us to tailor the chemotherapy. Coming down to selecting target therapy, we actually have multiple different platforms for molecular profiling, either utilizing circulating tumor DNA, or directly tissue profiling on the cancer cells. We could identify the mutations and identify potential therapeutic targets. Immunohistochemistry testing and FISH testing for HER2 remains very important for HER2 positive and HER2 low disease. And then lastly is PD-L1 expression, stands for programmed death ligand 1 expression, might be very important biomarker for immunotherapy. So the immunotherapy, maybe many people are already aware of this. This is really a very a novel drug and had a lot of efficacy in many other type of cancers, such as melanoma, lung cancer, and kidney cancer. The idea of the immunotherapy is very different from endocrine therapy, chemotherapy, or target therapy we heard before. It's really helping our own immune system start recognizing the cancer and attack the cancer cells. And then currently immunotherapy is only approved for triple negative breast cancer. And then we only have one drug called Keytruda approved in this space. Typically, we use immunotherapy in combination with the chemotherapy. And then there's a lot of ongoing clinical trials are exploring the different combinations using immunotherapy with target therapy and different chemotherapy. So in summary, the systemic therapy works throughout the body to treat and prevent cancer, which is different from surgery and radiation. Really, the goal is to live better and longer with less side effects. And I think ultimately we wanted to deliver a personalized, less toxic, more effective treatments for every patient. With that, I thank you for attention.
There's a bunch of questions in the chat. I think there's one that was made for you. It's are there different therapy approaches for older adults with comorbidities?
I love this question. That's actually a very important consider factor. So when we coming to decide what's the best systemic therapy for our older patients. As we all know, breast cancer is actually older patient disease. The peak instance is between age to 60 to 70s. And then when patient has comorbidities, it's very important to discuss with your breast medical oncologist about the disease status, about the treatment goal and the patient preference. And I think that there's a multiple validated calculators help us to predict the chemo-related side effects in older patient population. And then no, it's not one size fits all situation. We really have to be carefully to discuss all of those factors to come up with the best treatment approach. In general speaking, we believe older patients, breast cancer could be more indolent. However, there are aggressive types still happening in our older patients. We don't undertreat patients just because of the age. It really has to be individualized.
That's exactly how I see it too. You really have to know the patient and know what's best for them. So that makes so much sense. We'll go to Dr. Jonathan So, who is a breast radiation oncologist and a physician scientist at NYU Langone's Perlmutter Cancer Center. His lab focuses on precision radiotherapy and translating discoveries from the bench to the bedside. Today, he's going to discuss how we personalize radiotherapy for early breast cancer.
Hi everyone, I'm John So. I'm a breast radiation oncologist, and today we'll be talking about personalized radiotherapy for early breast cancer, how to decide between whole, partial breast, or omission of radiotherapy. So here are my disclosures. I have none. So we're going to talk about a few things. We'll talk about why we give radiotherapy, how many sessions of radiotherapy, how we decide on that. Should we treat the whole breast or only a part of the breast, and who is a candidate for omitting radiotherapy? So the trends, that we've noticed in the last 10 years, is really a move towards fewer fractions, smaller radiotherapy fields, where we really want to be more personalized to the individual risks and benefits. So really, as Dr. Z points out, it really isn't one size fits all. And so today's, radiotherapy is very different than what it was even 10 years ago. And the real goal is to maximize benefits while minimizing risks, and that'll be very different depending on the situation, depending on the person, their individual values, and what's important to them. So I like to talk, through cases, and so we'll start with a case, a compilation of a few patients that I've seen in clinic. So this is Pamela. So she's a 53-year-old accountant, lives with her husband, has two grown children, takes care of her granddaughter after school. She had a screen detected invasive ductal carcinoma, kind of breast cancer, and then for that she received a lumpectomy, that surgery to remove the cancer, and a sentinel lymph node biopsy, so removal of a sampling of a regional lymph nodes underneath in the armpit. The pathology shows this 1.5 centimeters, so it's small. We call it T1. 0 out of 2 sentinel lymph nodes are involved, so no lymph nodes are involved. This is N0. This is grade 2. So when we look at the cancer, the tumor, the cancer cells under a microscope, we grade them depending on how aggressive they look. So grade 2 is average, and we 1 being the least and 3 being the most. Her cancer was ER/PR positive, and that's also very common. And LVI is negative, so that's lymphovascular invasion, and that is a sign that maybe a tumor is invading blood vessels or lymph vessels when you look at it under the microscope. And that's negative. Margins are clear. So all of these clinical factors are sort of what we use to gauge risk of recurrence, risk of metastases, and that would really help us to gauge and personalize what kind of adjuvant treatment to give. Her Oncotype score was 15. You may have heard of this. This is a a specialized molecular genetic test that's done, and that really tells you whether or not you would really benefit from chemotherapy. And then she was referred to radiation oncology for a consult to see me. So what is radiation? Just very, very briefly. It's a type of electromagnetic energy, so you can't see it. It sits here. It has higher energy than visible light or ultraviolet rays. And it's very similar to, let's say, a chest X-ray that you were to receive. The dose, the amount of energy that we give is measured in gray, or GY, and it's delivered by a linear accelerator. So that this machine down here, that's actually very similar to a chest X-ray machine that you may have seen, but bigger. The radiation is painless. It goes right through the body. It doesn't stay in the body, so you aren't radioactive, and you won't be emitting radiation to people around you. So very safe to be around children or pregnant women. I get that question a lot, and it really is like getting a chest X-ray. How it works is it damages DNA, and it's able to target cancer because cancers have impaired DNA repair. And the side effects that we get after radiation therapy is really only in the area that we're giving the radiation. So the more targeted we can be, the lower the side effects. So how is it given? Well, so the order in which it's given is patients receive a surgery. So in this case, lumpectomy and a sentinel lymph node biopsy, and then depending on their clinical factors, the Oncotype score, it may be recommended to receive chemotherapy, and then they would receive that first. But if not, then they would proceed straight to radiation therapy. And then following radiation therapy, there is that hormone therapy for 5+ years. So the first step is really CT simulation scan. So the patient is in a treatment position, and here the patient is in a prone position or lying down, and we'll talk more about that later. This takes about 1 or 2 hours, and it's a regular CT scan, and allows us to really target the radiation to where we want to give it each time, each day. So we're able to be accurate to within a few millimeters. And then using the pictures that we get from the CT scan, we then plan the radiation. So with the help of computers, we calculate how to deliver this dose by customizing the beam angle, energy, and shape. So the top right picture here is axial CT scan. So straight across the body here, you see the heart on this side, the two lungs here, and the more red the contour here, the higher the dose. And this is an example of whole breast radiation. And this is a technique called prone radiation, where the patient is lying down, and so the breast hangs down, hangs forward. So that pulls the dose away from normal structures like the heart and the lung that you see here. And so that's very important in terms of decreasing side effects, especially late side effects. The lower left here we see is partial breast radiation. So instead of targeting the whole breast, we're really just targeting the tumor bed or where the tumor was, the surgical cavity. And so that's smaller field than whole breast radiation. Um, and then we can give us about a week to do the planning, and then we proceed to treatment delivery. And so radiation treatment is every day, Monday to Friday, and for about 30 minutes each day. And on the bottom lower right is a picture of the radiation therapy machine, the LINAC here. Okay, so the side effects of radiation can be really broken up between acute and late toxicities. So acute sort of side effects that can be experienced at the time of radiation therapy is fatigue, some skin redness, skin desquamation, or small areas of the skin opening up, itchiness, some pain, and then late side effects. So these are side effects that may continue months or years down the road. Our skin pigmentation changes, breast induration or hardness, breast shrinkage, lung inflammation, coronary artery disease, and very small risk of secondary malignancy. Because I tell patients we use radiation to cure cancer and prevent cancer coming back, but radiation also has the ability to increase our risk for certain cancers. But this is a very rare 1 in 1,000 type risk. So why do we give radiation? The margins are negative. The surgeon told me that everything was removed, and we really give it because previously all of breast cancer was treated with a mastectomy. It was considered a disease of the entire breast, and so the whole breast was removed. But subsequent trials in the 70s have shown that we get the similar rate of local recurrence and survival if we give smaller surgery, like a lumpectomy plus radiation. So this is breast conserving surgery plus radiation would be the same as a mastectomy. And here you see data from a bunch of different trials showing that after breast conserving surgery, if we give radiation, we're really able to reduce the chances of the cancer coming back in the same breast by more than 50%. And the secondary goal is then to preserve the breast in long term. So by preventing the cancer from returning in the breast, that would obviate the need for further surgeries or even a mastectomy down the road. So what are the choices for Pamela? Really, there are many. You can give radiation to the whole breast. That's 40 or 48 gray and 15 or 16 fractions, or shorter number of fractions, lower, so that would be 27 gray and 5 fractions, or partial breast radiation, 30 gray and 5 fractions, not to the whole breast, but to the lumpectomy cavity. And the evidence for this is really based on a few different trials. So this fast forward trial from 2020 randomized 4,000 patients to receiving 15, 16 fractions, which we have been giving for the last 30 years or so, to 5 fractions of whole breast radiation. The tumor occurrence, as you can see, is very similar between the two, but there was slightly less acute skin redness with 5 fractions, but more late breast induration or hardness. The breast felt a little bit harder. And so what does that mean? So here is how we grade skin redness or skin dermatitis. And it's graded from a scale of grade 1, 2, or 3. You can see from the pictures here. You can see that from the with the 5-fraction regimen, there's slightly less skin redness, acute skin redness. But the numbers are low in general. In terms of late side effects like breast induration, we see so here is breast induration at baseline 3 months, 6 months, 12 months, 24 months, and 60 months. And on the left is the 40 grade. This is the 15 or 16 fraction, the more conventional treatment. And on the right is the 5-fraction regimen. And you can see there's slightly more patients who report quite a bit or very much breast hardness or firmness 60 months after their breast radiation. But that's maybe about a 5% difference. So small, but significant depending on the patient. So for Pamela, really, when we spoke to her, she was a great candidate for either 15 or 16 fractions or 5 fractions of radiation. But because of the life that she led, she lives 30 minutes away from the cancer center. Coming in every day would be very stressful, especially taking care of her granddaughter. And so, 5 fraction of breast radiation would be very, very reasonable for her. Um, Also, we might even be able to shrink the field, and that's partial breast radiation. So this is a trial, and I'll skip over a few slides here. In the interest of time, this is a trial which randomized patients to whole breast versus partial breast radiation, and you can see by the graph here, the tumor recurrence is very similar. And then, as you can imagine, with partial breast radiation, there's less skin redness, less breast induration or hardness, and better patient-reported cosmesis. And so, for definitely lower risk individuals, partial breast radiation is very, very reasonable. And what do I mean by low risk? Well, um, various organizations have come up with these criteria that would allow us to determine, based on these clinical factors that we talked about, how suitable a patient would be for partial breast radiation. So, and then there is a middle column, which is more cautionary, where um, if you have any one of these criteria, you can still get partial breast radiation, but you have many of these criteria, it's probably not a good idea. And then the last column would be those where if you had any of these criteria, that would be unsuitable. So for her and her criteria, she would be very, very suitable for partial breast radiation. Now, it'd be very, very different if we had a different patient. Let's say um, we talk about Pamela's mother. So she's 75 years old, walks with a walker, lives in a nursing home, has a history of stroke and coronary artery disease, and has the exact same clinical characteristics of her cancer. Well, in this case, we would talk about the omission of radiotherapy, and so this is a trial that was done a few years ago, the PRIME2 trial, which randomized patients with low risk, early stage ER positive breast cancer, but who were over the age of 65. And so it's important to say that even though radiation decreased the 10-year incidence of local recurrence quite significantly, um, from 10% without radiation to 0.9%, there was no difference in death from cancer at 10 years. And most of the deaths were actually not from cancer. So when you get older in age, you run into competing risks uh, of other comorbidities that you might have, like cardiovascular disease. And then it's important that these patients receive and are adherent to the hormone and endocrine therapy that a medical oncologist would prescribe. So in conclusion, breast radiation therapy for early breast cancer has changed really dramatically over the last 10 years. We're really doing better at reducing side effects and toxicity while retaining the same benefit with fewer fractions, smaller fields. And the decision is really, in the end, very highly personal and involves a discussion of clinical risk, but also the patient's own priorities and values. So yeah, thank you very much for your attention.
we have our lovely Dr. Douglas Marks, who is a breast medical oncologist at the PCC Perlmutter Cancer Center and an associate professor of medicine at NYU Grossman Long Island School of Medicine. He's also the director of our clinical trials office for Long Island and has a deep passion for treating patients with a personalized oncology care method. And he's really great at looking at effective standard of care therapies as well as innovative treatments that are under development and getting patients the right treatment. So take it away, Dr. Marks.
Thank you so much. It's a pleasure to be here with my close colleagues and to speak with you all tonight. So my task is to talk a little about clinical trials, which are a very important aspect of medical oncology care. These are my disclosures. I'm not talking about any specific trial tonight, so in any detail, so not so relevant, but still here. So I'm proud to be part of this very strong breast medical oncology group. There are 16 of us. You'll be hearing from Iris shortly, who is another oncologist in our group. I'll be happy to represent our group tonight. So, for breast medical oncologists, when I first meet a patient, I say, as a medical oncologist, it's my job to talk about what medical treatments I can offer my patients with either early or advanced breast cancer, or sometimes patients who may not have breast cancer but be at high risk, to reduce their risk of developing either recurrent breast cancer, which is breast cancer that comes back, or developing breast cancer in the first place. And breast cancer is still, while our treatments are great, is still a big issue. About 310,000 women were diagnosed with breast cancer last year in the United States, and a little bit less than 3,000 men. And at Perlmutter, which is the cancer center at NYU, we saw over 2,400 new initial consultations. So a lot of new diagnoses we treat each year here. There have been different themes of practice in medical oncology as we've changed as science has advanced, and sort of what we feel is the main sort of issues that we're dealing with in our time. And in my career in breast oncology, I think there are two domains that are really important with talking and seeing patients. One is for patients with early stage breast cancer, determining which patients for whom remain at high risk after their initial breast surgery, for which we need more effective treatments, either more intense treatments or more tailored treatments, as well as which patients our treatments are so effective for that we can begin to look to reduce the intensity of their treatment. And one of my old mentors said to me, you don't get credit for curing a patient twice. Meaning everything we do after curing the patient the first time is really just extra and not, and sometimes even associated with toxicity. So we need to determine the optimal treatment for patients with early stage breast cancer. The second major, area of focus for breast medical oncologists has to be how to expand therapies for our patients who are already dealing with advanced breast cancer. This is breast cancer that has left the breast and the lymph nodes and is also considered called metastatic breast cancer. And for these patients, we need to extend the time period for which they have good quality and length of life. And as an example, for our patients with the most common type of breast cancer, which is estrogen receptor-driven breast cancer, we want to extend the therapy that we can provide them with targeted treatments before they, for example, need to go on chemotherapy. And for our patients that need chemotherapy, we want to work to develop better chemotherapies that are more targeted and have less side effects. The issue is that breast cancer treatment is complex. Breast cancer is a very diverse disease. Patients present with different types of breast cancers, and with therapies that work for certain breast cancers don't work for other breast cancers. We have hormonal therapies or endocrine therapies. We have biologic therapies, including immunotherapy. We have chemotherapy that we give, when indicated. And determining what patients need is only possible due to advances in our field made possible by clinical trials. So clinical trials are how we determine which treatment works for which specific type of breast cancer. And in our group, we have over 30 clinical trials trying to, for each subtype of breast cancer, determine what the best therapy is for them, these patients. So very briefly, what is a clinical trial? In general, it's a study to look whether a medical strategy, either a treatment or device, or possibly an exercise intervention or a non-pharmacologic intervention, how it impacts a patient's outcome. These studies should represent a later stage in research. So this is not, even when studies are being, patients are being treated early in a phase 1 study, which means that it's beginning its development. There's always a basis, or should always be a basis, in science. And so when we decide which studies we open, it's always because we've seen the beginning science support that drug, for example, being effective in breast cancer models. There's always lab work that goes into this. This represents a later development in stage of research, and it helps lead to the evidence that eventually guides our practice. Clinical trials have phases. You may hear these words used. Phase 1 studies are the studies that are recently from the developed technologies in our laboratory setting. These are looking at drug safety, and they're the first time that drugs are given to patients. And so usually these studies have a small number of patients. Their drugs are often tailored for their type of cancer, but they're early in development. So we're looking first to see, are these drugs safe and at what dose should they be given? Then trials, then these drugs, for example, can move forward to phase 2 if there's a sign that they're working and that they're not, they have acceptable toxicity for patients and not too many side effects. And in phase 2, we look to see, are the drugs really working compared to what we'd expect based on what we currently have available to us? And those studies have a slightly larger patient population, and they look at patients for longer periods of time. And then after that, drugs enter a phase 3 period. And this is the period where they get the closest to approval. And this is really when studies are larger, with larger number of patients to confirm what the expected benefit is. And patients are watched for longer periods of time. Sometimes you might hear something called a phase 4 study. This is a study that after a drug is approved, just to make sure it's safe on the market when people are being given it in their doctors and their communities. Just a few words about when your doctor talks to you about a clinical trial, it may say some terms that are somewhat hard to understand if you're not sort of in the mix of it. These are what a doctor bases their decisions on when determining whether a drug is working. And these terms are looking at different patient outcomes. One thing your physician may mention to you is that this study is a phase 3 study based on a phase 2 study, and that this study looks at overall survival. Overall survival means, does the intervention or the drug, in the case of many studies, actually lead to patients living longer versus not receiving the drug? And this is sort of our gold standard. We really want to make sure that patients are really benefiting in this deep way from our treatments. Sometimes this is a little bit of a longer follow-up period. So your physician may also mention something called progression-free survival. This means that, how long did the patient live on the intervention or drug without having their disease progress? And that means without their disease spreading or new spots of disease developing. And that's also an important outcome, because for many patients, when progression happens, it's associated with symptoms or shorter lifespan. So we look to see what drugs extend the amount of time patients can live with their disease well controlled. And there's also something called response rate, which is that, you might ask your physician, well, how many patients had their tumor shrink? And these are the percentages of patients that their tumor shrink beyond a certain time point. And both the doctor and the patients love to see tumors shrink. So we do provide these numbers when asked. But the two other metrics, whether patients are living longer and whether their tumors are being controlled and moving the right direction, are often more important than the percentage of tumor shrinks. But we do provide these numbers in the context of clinical trials as well. I want to just address a couple of issues with clinical trials that sometimes patients raise to us. One is, why do clinical trials have to be randomized? Or why do we sometimes see our patients have to, why do we not know exactly what they're treating? And the reason is because randomization allows us to evaluate whether the intervention or the drug that we're giving is actually responsible for the benefit or lack of benefit that we're seeing. For example, when we put a patient on a clinical trial, it's usually because we feel that that's what could very well be a good intervention or drug for the patient. And if we were able to select out, which patients went on which arms, many physicians would select, obviously, the treatment arm for their patients. Also, we want to make sure that the groups of patients that get the drug or get the intervention are balanced in terms of age and other medical issues. And randomization allows us to be sure that what we're actually looking at in terms of how people do is due to the drug or intervention. Sometimes you will ask, why do we blind patients? Why do we not know? And it's important what the patient is getting in some studies. And this is also to reduce the physician potentially, feeling that, a certain outcome that they're observing is due to the drug if they know in advance. But I would like to tell patients, I'm often asked by patients like, is this study blinded? And that means, am I not going to know what I'm getting? And actually the majority of studies we do are not blinded. Some studies are blinded, but most are not. So if blinding is an issue, do not assume that your study will be blinded. Ask your physician about it, because it quite very well may not be. I just wanted to end with just one more slide, just talking about one of the biggest misconceptions, which is that clinical trials are only for patients who have gone through every other type of treatment. You know, clinical trials are absolutely not for patients who have no other treatment options. In fact, you know, it is important to have a clinical trial for option for every point of patient's disease. We need to try to improve treatments for stage 1, stage 2, stage 3, and stage 4 disease. And that's what I show here, that each of these numbers is that the number of trials we have for each stage disease in our group, really trying to make sure that we have a trial for patients to improve the outcomes, no matter where they stand, whether they have a highly curable disease or whether they have disease where we're treating them as if, you know, it's a more chronic situation. And with that, I will finish, and I would love to take any questions now, or feel free to email me afterwards if we don't have time.
That's so great. Wonderful. Thank you, Dr. Marks. What are the risks, side effects, and outcomes seen so far with vaccine clinical trials for breast cancer?
I think this is a very exciting area. I think the caveat is that there are different types of vaccine trials. There are vaccine trials for patients who already have breast cancer, where you're taking their cancer and developing a vaccine against components of their cancer that they can then receive the vaccine after their initial treatment to prevent their cancer from coming back. And then there are vaccines that are being developed to prevent the primary development of breast cancer. And these are very the vaccines that are being developed against existing breast cancer tissue is a lot simpler to do, although these are still in development, mostly phase 1 and phase 2 studies. I do think that this is an exciting, direction we're moving, but we don't, for example, have an FDA-approved vaccine yet. But both of those spaces are where we hope to have vaccines be effective.
What is one of the most common questions or concerns that you get when talking to patients about a clinical trial?
I think that the number one concern that patients have is that it's possibly that they're the first patient that's ever received a treatment, or that they would be the only person that have been evaluated with, and that's almost never the case. Usually, we look to earlier phase data for more phase 2 and phase 3 trials, and in our early phase 1 trials, like I mentioned, there is a scientific background for every study we elect to open. We put a lot of thought into which trials we activate, and we're thinking about these studies as if they are treatment for our patient. I think some patients think perhaps that they're just participating for knowledge. While knowledge is important, whenever I'm talking about a clinical trial with my patient, it's also for their treatment. And so I'm putting a lot of thought into whether that option is actually better than what I could give them as standard of care.
Thank you, guys. Thank you, everyone, for joining us tonight. And tune in a couple weeks for the third segment.